Welcome to Wally's Nursing Videos. Today, we will explore the topic of pediatric heart conditions. I hope you find the following useful in your preparation for a career in the nursing field. Lecture on ventricular septal defect, VSD. Today, we'll be discussing ventricular septal defect, one of the most common congenital heart lesions. Let's delve into its characteristics, clinical manifestations, and treatment options. Most common lesion, VSD is indeed one of the most common congenital heart defects, accounting for a significant portion of cases. Opening between ventricles, VSD involves a hole in the septum, the wall that separates the two lower chambers of the heart, known as the ventricles. Left to right shunt. Blood flows from the left ventricle where it's oxygen-rich to the right ventricle, mixing with oxygen-poor blood. Common in trisomy 21. Individuals with trisomy 21 or Down syndrome have a higher incidence of VSD. Clinical manifestations. Symptoms can range from asymptomatic to signs of heart failure, depending on the size of the defect. A characteristic machinery-like murmur may be heard on auscultation. Treatment. While some small VSDs may close spontaneously, others might require intervention. Surgical options include suturing or patching the hole. Medical management might involve medications to manage heart failure symptoms or promote closure, such as NSAIDs like indomethacin. In some cases, a pulmonary artery band might be used to decrease blood flow to the lungs. Now let's move on to discuss another common congenital heart defect, patent ductus arteriosus, PDA. Lecture on patent ductus arteriosus, PDA. Today, we'll explore patent ductus arteriosus, PDA, another significant congenital heart condition. Let's delve into its characteristics, clinical manifestations, and treatment modalities. Opening between right and left atria, PDA involves a persistent opening between the aorta and the pulmonary artery, which should typically close shortly after birth. Clinical manifestations. Symptoms can vary depending on the size of the PDA. While small PDAs might remain asymptomatic and go unnoticed, larger ones can lead to symptoms such as signs of congestive heart failure, CHF. However, smaller PDAs might still contribute to CHF development over time. Treatment. Spontaneous closure can occur in some cases, especially with smaller PDAs. However, larger PDAs might require intervention. Surgical closure involves the insertion of a patch to close the ductus arteriosus. Non-surgical options include catheter-based procedures, where a closure device is inserted through a catheter and deployed to block the opening. Medical management focuses on treating symptoms of heart failure if present. Now, let's discuss atrial septal defect, ASD, another congenital heart anomaly characterized by an abnormal opening between the atria. Lecture on atrial septal defect, ASD. Let's delve into atrial septal defect, ASD, a congenital heart defect characterized by an abnormal opening between the atria. We'll explore its features, clinical manifestations, and treatment options. Aortic constriction where DA used to be. ASD involves a communication between the atria, which can lead to changes in pressures within the heart. Pressures. This abnormality can cause increased pressure in the upper body and extremities, while decreasing pressure in the lower body and extremities. Clinical manifestations. Manifestations can vary widely. Bounding pulses in the upper extremities and decreased or absent pulses in the lower extremities might be observed. Infants may present with symptoms of congestive heart failure, while older children might experience dizziness, headaches, fainting, or nosebleeds. Treatment. Surgical repair is often necessary to close the defect. This can involve various techniques such as direct suture closure or patch placement. Catheter-based interventions like balloon dilation or stent placement might also be options depending on the specific characteristics of the defect. Now, let's transition to discussing coarctation of the aorta, COA, a condition involving narrowing of the aorta, which can lead to significant hemodynamic consequences. Lecture on coarctation of the aorta, COA. Today we'll explore coarctation of the aorta, COA, a congenital heart defect characterized by narrowing or stricture of the aorta. Let's delve into its features, clinical manifestations, and treatment strategies. Stricture or narrowing of the aortic valve. COA involves a constriction in the aorta, leading to increased resistance to blood flow and decreased cardiac output. Clinical manifestations. the presentation can vary depending on the severity of the narrowing. Newborns might exhibit symptoms such as faint pulses, hypotension, tachycardia, and poor feeding. Older children may experience exercise intolerance, chest pain, dizziness, and fainting, particularly with prolonged standing. A characteristic murmur might be detected upon auscultation. Treatment: surgical intervention is typically required to relieve the narrowing and restore normal blood flow. This might involve surgical replacement or dilation of the affected segment of the aorta. Now, let's discuss aortic stenosis, another congenital heart defect characterized by narrowing at the entrance to the pulmonary artery. Lecture on aortic stenosis. Aortic stenosis is a congenital heart defect characterized by narrowing at the entrance to the pulmonary artery. Let's explore its features, clinical manifestations, and treatment options. Narrowing at the entrance to the pulmonary artery. Aortic stenosis involves a narrowing or obstruction of the pulmonary valve, leading to increased resistance to blood flow and decreased pulmonary blood flow. Clinical manifestations: the severity of symptoms can vary widely. They can range from asymptomatic to mild cyanosis to congestive heart failure. A characteristic murmur may be heard during auscultation. Treatment: surgical repair is often necessary to correct the narrowing and restore normal blood flow. This might involve techniques such as surgical repair or non-surgical dilation of the valve. Now let's transition to discussing tetralogy of Fallot, TOF, one of the most common complex heart diseases characterized by 4 specific defects. Lecture on tetralogy of Fallot, TOF. Tetralogy of Fallot, TOF, is a complex congenital heart disease characterized by 4 specific defects. Let's explore its features, clinical manifestations, and treatment options. Most common complex heart disease, TOF, consists of 4 defects abbreviated as VORP. V. Ventricular septal defect, VSD. O. Overriding aorta. R. Right ventricular hypertrophy. P. Pulmonic stenosis. Hemodynamics. The pressure and shunting patterns within the heart depend on the severity of these defects. Clinical manifestations. Symptoms can vary, with varying degrees of cyanosis being the most common. Some individuals may have normal oxygen saturation, pink TOF, while others may experience cyanosis, blue TOF. Hypercyanotic spells, characterized by the acute episodes of cyanosis and hypoxia, are a significant concern. Treatment: surgical intervention is often necessary, especially in severe cases. Palliative procedures may be required in severe cases, while corrective surgeries may be appropriate for milder forms of the condition. Now let's discuss hypercyanotic spells, TET spells, which are acute episodes of cyanosis and hypoxia commonly seen in patients with TOF. Lecture on hypercyanotic spells, TET spells. Hypercyanotic spells, also known as TET spells, are acute episodes of cyanosis and hypoxia commonly seen in patients with tetralogy of Fallot, TOF. Let's explore their presentation, precipitating factors, and management strategies. Patient presentation. During a TET spell, individuals may exhibit altered levels of consciousness, cyanosis, diaphoresis, increased respiratory rate and heart rate, irritability, and even seizures. Precipitating factors. These spells often occur during activities that increase oxygen demand, such as crying, eating, or arising from naps or sleep. Tachycardia can exacerbate the shunting of blood from right to left, further reducing pulmonary blood flow. Nursing management. Nurses play a crucial role in managing TET spells. Measures such as calming and soothing the child, positioning in a knee-to-chest position to increase systemic vascular resistance, administering intravenous fluids, and providing oxygen to increase systemic oxygenation are essential. Additionally, squatting, a characteristic behavior seen in patients with TOF, can help increase systemic vascular resistance and alleviate cyanosis during TET spells. Let's now move on to discuss transposition of the great arteries, TGA, a congenital heart defect characterized by a reversal of the great arteries. Lecture on transposition of the great arteries, TGA. Transposition of the great arteries, TGA, is a congenital heart defect characterized by a reversal of the great arteries. Let's explore its features, clinical manifestations, and treatment options. Reversal of great arteries. In TGA, the aorta arises from the right ventricle, while the pulmonary artery arises from the left ventricle, resulting in parallel independent systemic and pulmonary circulations. Clinical manifestations. Symptoms vary depending on the specific type of TGA. Without a septal defect or patent ductus arteriosus to allow mixing of oxygenated and deoxygenated blood, infants typically present with severe cyanosis shortly after birth. Other manifestations may include poor growth, activity intolerance, and signs of heart failure. Treatment. Prostaglandin administration to maintain patency of the ductus arteriosus is crucial in stabilizing infants with TGA. Surgical correction is typically required to redirect blood flow appropriately. Now let's discuss another complex congenital heart defect, truncus arteriosus, characterized by a single great artery arising from both ventricles. Lecture on truncus arteriosus. Truncus arteriosus is a complex congenital heart defect characterized by a single great artery arising from both ventricles. Let's explore its features, clinical manifestations, and treatment options. Underdeveloped left side of the heart. In truncus arteriosus, the left side of the heart is underdeveloped, leading to pulmonary venous congestion and edema. A patent ductus arteriosus is required for systemic blood flow. Clinical manifestations. Patients typically present with progressive cyanosis, decreased cardiac output, signs of heart failure, and, in severe cases, may experience life-threatening complications shortly after birth. Treatment. Stabilization with prostaglandin E is crucial to maintain ductal patency. Surgical repair is the primary treatment modality, although transplantation may be considered for older patients with severe complications. Now let's move on to discuss hypoplastic left heart syndrome, HLHS, a severe congenital heart defect characterized by underdevelopment of the left side of the heart. Lecture on hypoplastic left heart syndrome, HLHS. Hypoplastic left heart syndrome, HLHS, is a severe congenital heart defect characterized by underdevelopment of the left side of the heart. Let's explore its features, clinical manifestations, and treatment options. Defects. HLHS is characterized by several defects, including hypoplastic left ventricle, atrial septal defect, small aorta, and patent ductus arteriosus. These abnormalities result in inadequate systemic blood flow and oxygenation. Clinical manifestations. Infants with HLHS typically present with profound cyanosis, decreased cardiac output, and signs of heart failure shortly after birth. It is considered one of the most severe forms of congenital heart disease and is associated with a high mortality rate without intervention. Treatment. Stabilization with prostaglandin E is crucial to maintain ductal patency. Surgical repair involves a series of staged procedures to reconstruct the heart's anatomy and improve systemic blood flow. Now, let's transition to discussing acquired heart diseases, starting with inflammatory diseases such as rheumatic fever. Lecture on rheumatic fever. Rheumatic fever is an inflammatory disease caused by Group A streptococcus infection. Let's explore its features, diagnostic criteria, clinical manifestations, and treatment options. Caused by Group A strep, rheumatic fever typically develops following an untreated or inadequately treated streptococcal infection, such as strep throat or a skin infection. Diagnostic criteria, Jones criteria. Diagnosis is based on the presence of major and minor criteria. Major criteria include carditis, polyarthritis, erythema marginatum, subcutaneous nodules, and chorea. Minor criteria include fever, arthralgia, prolonged PR interval on ECG, and elevated inflammatory markers. Clinical manifestations. Carditis, characterized by inflammation of the heart, is the most serious manifestation of rheumatic fever. Patients may present with an apical systolic murmur, mitral regurgitation, and, in rare cases, heart failure. Treatment. Prompt treatment of streptococcal infections with antibiotics, such as penicillin, is crucial in preventing rheumatic fever. Management of inflammation and fever may require the use of anti-inflammatory medications such as aspirin and corticosteroids. Now let's discuss another inflammatory disease, Kawasaki disease, which is a leading cause of acquired heart disease in the United States. Lecture on Kawasaki disease. Kawasaki disease is an acute systemic inflammatory disease of unknown cause. Let's explore its features, clinical manifestations, and treatment options. Leading cause of acquired heart disease in the U.S., Kawasaki disease is a systemic vasculitis that predominantly affects children, particularly those under the age of 5. Clinical manifestations. The disease is characterized by fever lasting for at least 5 days, along with at least 4 of the following clinical features: changes in the extremities, polymorphous exanthem, non-exudative conjunctivitis, changes in the oral cavity, and cervical lymphadenopathy. Complications may include coronary artery aneurysms. Treatment typically involves intravenous immunoglobulin (IVG) administration to reduce the risk of coronary artery complications. High-dose aspirin may also be used to manage inflammation and fever. Close monitoring for cardiac complications is essential during and after the acute phase of the disease. Now let's discuss the nursing care for children with cardiac disorders, including strategies to improve oxygenation, promote adequate nutrition, prevent infection, and assist with coping. Lecture on nursing care for children with cardiac disorders. Nursing care for children with cardiac disorders plays a crucial role in promoting optimal outcomes. Let's explore key aspects of nursing care, including improving and maintaining expected oxygenation, promoting adequate nutrition, preventing infection, assisting with coping, providing education and anticipatory guidance, and delivering post-operative care. Improving and maintaining expected oxygenation. Nurses monitor oxygen saturation, administer supplemental oxygen as needed, and ensure proper positioning to optimize respiratory function. Promoting adequate nutrition. Nutritional support is essential for growth and development. Nurses monitor intake, administer enteral feedings as needed, and collaborate with dietitians to meet nutritional needs. Preventing infection. Infection prevention strategies include hand hygiene, aseptic technique during procedures, and monitoring for signs of infection. Assisting with coping. Nurses provide emotional support to children and families, assess coping mechanisms, and facilitate access to support services. Providing education and anticipatory guidance. Nurses educate families about the child's condition, treatment plan, and potential complications. Anticipatory guidance helps families prepare for upcoming procedures or lifestyle changes. Delivering post-operative care. After cardiac surgery, nurses monitor vital signs, assess for complications, manage pain, and facilitate early mobilization and rehabilitation. In conclusion, nursing care for children with cardiac disorders requires a comprehensive approach that addresses physical, emotional, and educational needs to promote optimal outcomes and improve quality of life.